Good afternoon, everyone. Thank you again for joining us for today's webinar, Navigating Prostate Health Understanding BPH with Dr. Nakota from JFK University Medical Center. If you have any questions, you may ask them anonymously by clicking on the Q&A button at the bottom of your screen. But please note that if you do type your question into the chat, it will not be anonymous and all attendees will be able to see your question and name. We will make sure that all questions are answered at the end of the webinar. This webinar will be recorded and sent to the email address that you registered with, along with being uploaded to the Hackensack Meridian Health YouTube channel. Thank you again for joining us today, and I'll pass the floor over to Dr. Nakota.
Good afternoon. I'm Dr. Zane Nakota, and thank you for joining us today to talk about BPH, or benign prostatic hyperplasia. So I'll start off by just telling you guys a little bit about myself. I'm a urologist here in the Edison area, and I'm affiliated with JFK University Medical Center. I grew up in the Philadelphia area, and then I went to the West Coast to Los Angeles, where I did my surgical and urology residency training at the University of Southern California. And then I've been back here for the last 6 years practicing in the local area. So our agenda for today, there we go, is to first start off with an overview of what is benign prostatic hyperplasia. We'll then talk about how we diagnose BPH and some of the tests that we do in the office. And then finally, our main focus really will be on the various treatment options for BPH. And this is a topic that's of special interest to me because it is an area that I really focus in on and I find to be the most interesting. And I can hopefully give you some insight on why BPH is important, not just for symptom relief, but also your overall bladder and prostate health. So to start with, we'll do an overview of the prostate. The prostate is a small walnut-sized gland that sits right there at the base of the bladder. And its job really is to produce fluids that transports the sperm during ejaculation. And it does wrap around the urethra, kind of like a donut. And as men get older, the prostate starts to grow as well, and it can obstruct the urine flow from coming out. So BPH, or benign prostatic hyperplasia, is basically what it says, which is the prostate growing bigger and bigger. Now, the one important thing to know is that BPH in itself does not equal prostate cancer. It is something that we screen for when we have our visits, but the two are two separate conditions, and our focus today really will be on benign prostatic hyperplasia. And this is an extremely common condition. Typically, the prostate starts to grow once you hit around 40 years old. Over 40% of men in their 50s and over 70% of men in their 60s will have BPH. So there is a general correlation that as the prostate is bigger, you tend to have more symptoms. And we call those LUTs, which stands for lower urinary tract symptoms. But the other thing I always tell my patients is that the actual size does not always correlate with the degree of symptoms and obstruction. I have patients who have very small glands, but the way that it is obstructing the urinary flow on the inside is much more obstructive than someone who has a very large gland, but has an open channel on the inside for the urine to flow through. So how do you know whether you may have BPH? So there are several symptoms that you would look out for when that prostate is obstructing the urine flow from coming out. One of the common ones is the urine flow just gets weaker. It takes longer for you to come out. You may get to the bathroom. You may have to stand there for a while before the urine flow starts. And then it may start and stop instead of having one steady continuous stream. A lot of patients, this is oftentimes a very gradual process where you may not really realize it. And a lot of patients say, hey, when I'm in the bathroom stall and the person next to me gets there, pees with a strong flow, is out of there in a few seconds, and I'm there for a few minutes, that's when they really notice the difference. The other part is also some irritative symptoms. So you'll feel the urge to pee very frequently. When you get the urge to urinate, it's difficult to delay it, and you have to run to the bathroom right away. And then also getting up multiple times per night. So as you mentioned before, BPH by itself does not mean prostate cancer. Men can have very, very large prostates that are just benign, non-cancerous growth, and men can have very small prostates where prostate cancer can develop. The two do not correlate any way, shape, or form. So having a larger prostate does not increase your chance of having prostate cancer, while having a smaller prostate does not decrease your risks. The two can coexist. So just because you have a large prostate, you can develop cancer as well. And we always try to identify and rule that out during our workup. One of the most common tests that we will do is a test called a PSA, which stands for a prostate-specific antigen. This is an enzyme that is produced by the prostate gland and only by the prostate gland. And we use that as a tool to see who is at a higher risk of having cancer or not. Unfortunately, it is not a perfect test. It can be elevated for non-cancerous reasons, which can sometimes be the prostate being enlarged. It can be due to inflammation or infection or other causes. And so the PSA in and of itself is not the final decision-making on whether you have cancer or not. And if the PSA is elevated, we'll often do additional tests such as biopsies or MRIs to help it distinguish whether the PSA elevation is just from enlarging prostate or cancer. Now, the second part that I think that many urologists and many other physicians don't focus on with BPH is the concept of bladder health. And the bladder and the prostate really go hand in hand. And I think of the bladder to have two functions. The first function is it has to be able to store the urine until it gets full. And the second job it has to do is to pump the urine out through the prostate and through the urethra for you to empty out your bladder. And it's basically is a pump, just like the heart. And one of the things that happens is when the prostate is enlarged and is obstructing the urine flow from coming out, that bladder pump has to squeeze harder and harder and harder to get the urine flow out. As that bladder pump squeezes harder and harder, it does start to get thicker and it does start to get weaker. And over time, you can get a permanently damaged bladder. Some of the symptoms that you'll see as that bladder loses some of its function is that you hold a smaller capacity, you may get more frequency, more urgency. And in very late stage bladders, the bladder stops working altogether, where it's not able to generate the squeeze or the force to get the urine out. So the idea of bladder health is important because if we can decrease how hard the bladder has to work, we can slow down the progress of any bladder damage or breakdown. And any bladder damage or breakdown, unfortunately, is a one-way street. At this time, there's no medications, there's no surgeries to undo any damage to the bladder. So how do we diagnose BPH? So when you come into the office, we will usually start by first doing a medical history. That involves just talking about what your symptoms are. But we always also have you fill out a questionnaire form called an IPSS form, which I'll show you in a second. The second part we'll do is a physical exam. So we will do a full men's health exam, including a rectal exam to feel if the prostate feels enlarged, and also to evaluate for any lumps or nodules, which could be a sign of prostate cancer. We'll typically do a blood test called a PSA test, which, as we mentioned before, is to screen for possible prostate cancer. We'll do a urinalysis test to look for any evidence of infection, blood in the urine, things such as that. A lot of the times, some of the urinary symptoms may be not related to BPH or bladder. It could be related to your fluid intake and your behaviors. And so we'll often try to get a good summary of what are you drinking? How much are you drinking? Are you drinking too much right before bed? And that's why you're waking up so many times. And keep a diary of how much you're drinking, what you're drinking, and what times. Another test we often will do is what's called a uroflow test. For this one, you will be asked to come into the office with a full bladder, and you'll pee into a machine that will measure how fast the urine is flowing out. and at what rate, and is it come out nice and smooth, or is it coming out in spurts? And then we'll scan your bladder with a little machine to see how much of your bladder you're emptying out all the way and how much you're being left out. In the perfect world, you will have a nice strong flow that empties completely out. However, that test is also not perfect, because if you really use all your abdominal muscles and push really hard on your bladder, it may make it seem like your bladder is working really well when it's not. Secondly, we'll often try to get an idea of how large the prostate is. Typically, we'll use a prostate ultrasound to measure the volume of the prostate. That is best measured by putting a little ultrasound probe that goes in the rectum, just like the digital rectal exam, the finger exam that you would do on your first visit. At some point, we may decide that, we feel that this is a pretty important part where we're not getting an adequate control with behavioral changes or medications. And it may be worth to get a better idea of what is going on the inside. Is how big is the prostate, what is the shape of the prostate, and what is the current health of your bladder. And for that, we may recommend doing what's called a cystoscopy, where a small camera goes in the bladder to look inside. And then if we ever are not sure whether the prostate is the issue and it's more of a bladder issue or something else is going on, we may do some additional testing to evaluate your bladder health and help distinguish what the main problem is. So this is the score sheet I was talking to you about previously. It's called the IPSS, or the International Prostate Symptom Score. This, I find, is extremely useful for first of all, diagnosing BPH, and number two, monitoring patients' progress as we do different treatment options, and assess whether certain medications or procedures have been effective at decreasing your symptoms. Because it can be hard to remember what your symptoms are all the time. They can sometimes vary day to day. So this looks at questions like, do you feel like you're emptying your bladder all the way out? Are you going very frequently to the bathroom? Do you start and stop when you get the urge to go? Are you able to hold off on it? Is your flow weak? Do you have to push or strain to get the urine out? And how often you wake up? And everyone is different in terms of how much they're bothered by it. So the last question asks you basically a question about what is your quality of life? And to be honest, that question is more important than anything else that you put on there, because it tells me that, hey, some people may get up once per night, and this is extremely bothersome. It's difficult to fall back asleep. And I have other patients wake up 4 or 5 times a night and are really not that bothered by the symptoms themselves. And so how aggressive we are about treatment depends on how bothered you are by your symptoms, partially, and also the other bladder health piece that we spoke about before. So the cystoscopy is what we spoke about before. It's, again, a thin lighted tube that goes through the urethra all the way into the bladder, allows us to evaluate the prostate and the bladder. This can be done most of the times right in the office, where we put some local numbing medication and anesthetic. The procedure itself, again, takes less than a couple of minutes. And if that is gives you a lot of anxiety, we can also offer that under some light sedation in an outpatient surgery center. So what I like to really focus on today are the various treatment options. So I would say there are basically 3 main categories of options. The one that's not included is just behavioral changes. And to touch on that, it would be basically changing the way you live your life to match up with your symptoms. So for example, if you're now getting up multiple times a night, you may work on decreasing your fluid intake before you go to sleep. If some of your symptoms are a lot of urgency and frequency, we'll work on timing when you take fluids, when you're out traveling and you have access to a bathroom or not. Certain things like alcohol, caffeine, coffee do cause some irritative symptoms to worsen, and we work on cutting down some of those things. The second part is medications, and there are 3 main medications that we use. The most common are alpha blockers, such as Flomax. They help on relaxing the smooth muscles in the prostate to allow the urine to come out more easily. The second are 5-alpha reductase inhibitors, or finasteride is the most common one, or Proscar. Those work on shrinking the prostate down to make them smaller. They work on the hormonal level by blocking the conversion of testosterone to dihydrotestosterone which is what fuels the prostate growth. But those medications do take a while, between 6 months to a year, to notice an improvement. One of the newer medications of the last decade that we're also using is a medication called tadalafil or Cialis. You may have heard of it as used for erectile dysfunction, but a daily dose also helps to open up the prostate channel to help you urinate better. Then there are several minimally invasive surgical options, such as microwave therapy, which has really come out of favor because they were not that effective. Resume or steam treatments, urolifts, where we're able to pull the urethra with clips, laser prostatectomies, the TURP, which has been around for a while, aquablation, which is a water jet, and then a more invasive surgery where we go in and basically scoop out the entire inside of the prostate. And we'll go into a little bit more in the next slides about each of these. One question I often get from patients is, are there any supplements I can take or any dietary changes that I can make? Unfortunately, there have been a lot of data and the results have been mixed. And the general recommendation is that any supplements or phytotherapeutic agents are really not recommended as the primary treatment option for BPH. However, I find that taking any sort of prostate supplements, especially saw palmetto, really has minimal harm. And I've anecdotally had several patients who feel that they do much better when they take it. I think there's very little risk in taking those, but I don't think that they're a great replacement for BPH in and of itself. Dietary wise, there's not much you can do except for living a healthy life. So everything that's good for your body, like eating more fruits and vegetables, cutting down fatty foods, sugars, all of those are going to be important for maintaining your bladder and prostate health. We talked about watchful waiting, which is the talking about just making lifestyle changes. The alpha blockers, or the medications that relax the smooth muscle of the prostate. Now, there are some side effects from these medications. They can cause a slight drop in blood pressure, so we have you take it right before you go to sleep. They can cause some dizziness, nasal congestion. The one that patients tend to be the most bothered by is something called abnormal retrograde ejaculation, which is when you have sexual activity, you'll still have the orgasm, but little or no semen may come out as it goes backwards into the bladder, as the medications relax the bladder neck, which prevent it from shooting forward. These are irreversible, and when you stop the medications, you will go back to normal. And then one other thing we also talk about is that it can cause something called a floppy iris syndrome, which ends up being an issue if you ever get cataract surgery in the future, and can make that surgery a little bit more challenging. The next one we spoke about were the medications to shrink the prostate down. And the main one about this is that it does lead to some sexual dysfunction. Most patients that do get side effects often complain about decreased sex drive, decreased libido, which can often lead to decreasing their performance in the bedroom as well. So this one sort of is a good slide because it shows us kind of the least invasive procedure all the way out to the most invasive procedure. So if we had this talk, I would say maybe 10, 20, 15 years ago, your options were basically you do nothing, you take medications, or we do what's called a TURP procedure where we shave the prostate down, which is a bit more invasive. It does often lead to a permanent loss of ejaculation, and especially for younger men, it was a little bit of an aggressive treatment option. Now we have a lot of options that are in between, which allow you to come off medications without getting some of the side effects of a TURP, with a much more quicker, faster recovery and less invasiveness. And then also a new procedure that I'm going to be excited to speak with you about at the end of the talk today called aquablation, which helps us get the same durable results from a TURP while maintaining a lot of the sexual function that you often lose with that procedure. So the first one we're going to talk about is called the urolift system. So the urolift system, this is a diagram where the camera is put inside and small implants are permanently placed in the bladder, essentially pull the urethra apart and create a space for the urine to flow through. And this is a little bit different than some of the other procedures in that none of the tissue is actually burned, cut out, or removed. We're just mechanically spreading them apart, kind of like the curtains on a window, to allow the urine to flow through. And you can see that the implants are there. They're made of nitinol and stainless steel. The only thing is if you have any sort of nickel or metal allergy, we do not recommend using this in case you may get a side effect from those. They're pretty small, the implants. They get covered by the mucosa and pretty minimal or low risk from any issues occurring from those implants. And what I'll show you next is a example of a video that shows how the procedure would be done. This can be done in the office. It can be done in an outpatient surgery center under some light sedation or in a hospital, depending on your preference. The procedure itself is relatively quick, typically takes about 10 to 15 minutes. And typically the average patient has between 4 to 6 clips put in, 2 to 3 on each side. So let me come out and I'm going to send you to the first video that we have here.
System is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructive prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press,
that is the needle that's traveling through the prostate and deploying at the outside of the capsule. The other part is a stainless steel tab that holds it in place, and there's a strong tension suture in between
depending on the prostate size
that
and blockage
keeps the
severity.
traction
The
open.
doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
Okay, so what I like about the UroLift procedure is that it's minimally invasive. It is the only one that can allow you to maintain your ejaculation 100% of the time. And after most of these procedures, we often leave a catheter in your bladder for a day or two. With the UroLift procedure, about half the time we can get away without any catheters at all, as long as there's not too much bleeding. The recovery is definitely a bit quicker, less irritative symptoms, within a couple of weeks, most patients are feeling much better. And the downsides are really the durability. These procedures are not cutting and opening up that prostate channel to the degree that a TURP or an aquablation procedure would do. So within 5 to 10 years, it wouldn't be unreasonable that the prostate goes bigger, the symptoms come back, and you may need an additional procedure down the road. But those are the trade-offs. You have a minimally invasive procedure, you maintain your sexual function, which is often important for many of my patients who are younger. And the other nice thing about the procedure is you don't burn any bridges. So let's say we have to move on to a more invasive procedure in the future, you haven't lost any of those options by having this done. The next one that is in that same class of minimally invasive options is something called Resume or water vapor treatment. This uses basically hot steam that's inserted through a needle into the prostate to help dissolve the tissue away. Each location that we put the needle instills 9 seconds of steam. Most patients need anywhere between, I would say, 3 to 5 needle sticks. So the whole procedure is literally done in 27 to 45 seconds. After the procedure is over, every patient does need a catheter, typically for about 2 days. And it does take about 6 weeks or so for you to get the full results. So early on, you're going to have issues with increased frequency and urgency and burning because all that tissue has gotten inflamed from the steam being in there. And over this next 6 weeks, as the inflammation settles down, the tissue sloughs off, patients see a remarkable improvement in symptoms. This one also has a very low risk of losing that ejaculation, and that risk is low, around 6 to 8%. So 92 to 94% of men are able to maintain normal ejaculation post-procedure. This one is done in the office, all with just local anesthetic. You don't have to be asleep at all for this procedure. So I'm going to show you a video of the resume treatment next.
Resume uses a fundamentally different way of applying thermal energy to treat lower urinary tract symptoms secondary to BPH. Each 9-second treatment uses 0.42 milliliters of radiofrequency heated sterile water vapor, which rapidly and uniformly disperses through the tissue interstices. The condensation of water vapor releases stored thermal energy. Cell membranes are gently denatured, thereby causing immediate cell death. The vasculature is closed, and there is denervation of the alpha adrenergic nerves within the treatment zone, providing you with an efficient, uniform, predictable treatment. Over time, this ablated tissue is resorbed by the body's natural healing response, reducing the volume of tissue, allowing the urethra to open, relieving lower urinary tract symptoms.
Okay. So next, we're going to talk about, again, the resume to recap, office procedure, pretty quick, about a 5-minute procedure, all under local anesthetic, catheter for 2 days, 6 weeks to recover. And the durability of this is similar to the UroLift, about 5 to 10 years. As a prostate grows bigger, you may need additional procedures down the road. 80% of men, I would say, who have either the UroLift or the resume procedure are able to come off long-term medications, which obviously carry side effects. And I think that's a great benefit to both of these without having to go through a very invasive procedure. So the TURP is the one that is sort of the gold standard. It's been around for decades, and it's still one that I use frequently. But it is definitely a more invasive procedure than the first two that I mentioned. This one uses electricity and a thin metal band to basically swipe small pieces of prostate tissue through the center until an opening is created. And as you see all these new procedures come out, like the ones we mentioned, they will often compare them to TURP, because that is considered still the gold standard in opening up the prostate and getting a good relief of the obstruction. Now, the TURP, unfortunately, is not perfect. It does require general anesthesia. It does require an overnight stay in the hospital, a little bit of a longer recovery time as you're cutting and burning the prostate tissue. So you're going to have some more irritation symptoms that can last anywhere between 4 weeks to sometimes 3 to 4 months out. Each person is a little bit different. Higher risk of bleeding as we're actually cutting through the prostate tissue and all the blood vessels to open up the channel. But you're going to get a very nice, big, wide open channel that tends to be much more durable in my experience, good for 10 or 15 years. The main downside I find of the TURP, other than the more invasive nature and the overnight stay and the general anesthesia, is the loss of ejaculation. So that ends up being something that is permanent. That is, I basically tell my patients that expect to not ejaculate any further after the surgery. So you'll still have erections, you'll still have orgasms, just no semen will come out. And again, this is something that cannot be undone. So the next, I'll show you a video about how the TURP procedure is done.
An instrument called a resectoscope is passed along the urethra to the prostate. This has a U-shaped loop through which an electric current passes. Here we can see the view as the resectoscope is passed. The first step is to inspect the bladder and identify the holes where the urine enters the bladder from the left and right kidneys. The operation involves taking loops of prostate tissue so that the prostate cavity is cut away from the inside. Small blood vessels are diathermied as they are encountered.
As you can see, you're basically taking little
You see here the
slices,
cavity is opening up nicely.
and each of those
Forming a
red things
wide
shooting
channel
out are
through
blood
which
vessels that are
urine
pumping
can
out
pass.
that will burn with our cautery loop. So as you can see, it creates a nice wide open fossa channel for the urine to flow through. And all those little pieces that are sitting in the bladder get drained out at the end of the case. And we send those for pathology to look for any cancer.
So that's a brief look at TURP.
Okay, so as I mentioned before, the TURP, I think, is a really good procedure. It's been around for a long time. And in the right patient, I think it's a very, very good procedure, especially for someone who really favors durability over some of the side effects. There are some limitations to the TURP, and one of those is the size of the prostate. So if your prostate is very large, typically we say that over 100 grams, it's difficult to get a reasonable opening through a TURP, and at least not from a single setting. And you may require multiple trips to the OR to get a final nice opening to that prostate. And the larger the prostate, the more time you're in the operating room resecting prostate tissue, which increases risk of anesthesia complications, metabolic complications, and increased risk of bleeding. The other one that I'll put in here is something called laser therapy or green light laser prostatectomy. This, similarly like a TURP, uses a laser to ablate the tissue away and create a channel. Some of the advantages of the laser prostatectomy is that there's a little bit less bleeding involved. Sometimes you can go home the same day without a catheter, but they often have a lot more irritative and burning symptoms afterwards. Personally, I'm not a huge fan of it, but it is definitely an option. And there are many urologists who find this to be their preferred option for treatment of the prostate. And the final one I'll sort of touch on is something called open or robotic prostatectomy, which is done for men whose prostates are very large, typically over 100 grams. In comparison, the average male prostate is typically around 40, maybe 50 grams. So these ones that are 2-3 times as big. And the way I think of it, of the explanation, is I think of it in orange. So the orange is your prostate. And when we're doing surgery for prostate cancer, the entire orange is removed. And that is a type of surgery that can lead to erectile dysfunction, urinary incontinence, things like that. With the simple prostatectomy, we go in and basically find the plane between the fruit of the orange and the peel, which is the enlarged prostate tissue that is causing the obstruction. and we basically carve out the entire fruit, take it out, and leave the shell behind, which is the prostate capsule. This gives you an amazing, really wide open channel. It's going to be very durable. It's going to be, because you stay within the capsule, you're going to maintain the nerves that supply the erections. You're going to maintain your continence, but it requires, much longer surgery where we either have to make a big incision in the abdomen and go through through the abdominal wall and open up the bladder, or many times we do this robotically, where we do robotic laparoscopic surgery, put an opening through the bladder that way and carve out the prostate that way. You do require to keep a catheter in anywhere between 7 to 14 days for the opening of the bladder to heal and for the fossa to epithelialize. And the biggest thing really is the significantly increased risk of bleeding. Much higher risk of needing a blood transfusion from the bleeding that occurs from all those small blood vessels that are opened up, that are really hard to cauterize that deep down in the pelvis. The robotic surgery does decrease a lot of those bleeding complications, but definitely they're still higher than the more minimally invasive options that we've talked about previously. So that brings us to aquablation, which is an exciting new technology that we have recently acquired at JFK Medical Center. We've done several cases and have had excellent outcomes. I think it's going to really revolutionize a lot of our prostate surgeries, especially in those prostates that are going to be a little bit larger, more than 50 grams, in men who want a more durable opening while still maintaining sexual function. So the prostate comes in not just different sizes, but also different shapes. You have prostates that are short and thick and wide. You have long, skinny prostates that are not as tall. You have prostates with tissue coming in laterally and obstructing them with what we call lateral lobes. You have prostates with a big median lobe, which is a big bulge of prostate tissue growing from the floor of the bladder that often grows inside the bladder. You have some prostates that are kind of really pushing inside the bladder, and you have other prostates that are more further away from the bladder neck. And all of these are little nuances that, as a specialist in BPH, we can differentiate all those different nuances and decide which procedure based on your wishes and desires is the best one for you. So in the small to medium-sized prostates, the TURP or the laser are kind of the best in terms of resecting the prostate and opening that channel. While the larger ones, you require what we call about the enucleation, where we do the simple prostatectomy and we carve out the prostate. These are the ones, as I said, are the resective ones. So we're actually removing tissue. They prioritize opening up the channel and giving you really good relief of the urinary symptoms. But unfortunately, the cost is your sexual function, where you're often losing that ejaculation. Most men do maintain normal erections. And there's also a small risk with any of these procedures about losing continence. They're relatively low risks, but definitely the resective ones carry a higher chance of that happening than the non-resective ones. The other ones we talk about the non-resective procedures. So those were the resume or steam treatment, or the urolift, where we lift the prostate apart. These ones don't open up the channel quite as well as the other ones, where we were actually resecting and removing prostate tissue, but they do prioritize that sexual function. And for many patients who are not having very severe BPH symptoms or severe obstruction, it often is all that you need to open up the channel, feel better, get off medications, and maintain the normal sexual function. And then there's this aquablation, which sort of can be used for all shapes of prostates, all sizes of prostates, while still maintaining the sexual function in a vast majority of men. So the way aquablation works is that it uses two modalities to determine what parts of the prostate need to be removed. So all the other prostate procedures we talked about before, all done cystoscopically. The camera goes to the urethra and the penis, and under vision from the inside of the urethra, we determine what is cut out. We're working from the inside out towards the capsule. With aquablation, we first start actually by putting an ultrasound probe directly in the rectum. And with the ultrasound probe, we can map out how far the prostate capsule is, where the adenoma tissue is, where the bladder neck is, and where the ejaculatory ducts enter into the prostate. And once we put that in, we then go ahead and put a camera in cystoscopically as well. And then we do a lot of planning and mapping on the ultrasound, determine which parts of the prostate we want to resect, which are causing the obstruction. And then we try to minimize any resection over the area of the bladder neck and near the ejaculatory ducts, which are the two things that are important in being able to maintain ejaculation. Once we've done all of our mapping, we'll use a heat-free water jet to resect the tissue. And then once all of those passes are made, which is done through a robotic approach, we enter with the camera, just like a TURP, clean up any spots or remaining tissue that needs to be removed, cauterize any bleeders, and then the recovery is similar to a TURP in the post-operative process. So this is an example of what kind of mapping we would do. So what you will see is that number one is in this prostate, it has a large median lobe. That's the tissue I was talking about, where it would grow from the floor of the bladder and grow inside the bladder. So we first talk about mapping out that part of the prostate, and as you can see, we've told the robot to resect that tissue. Number two, where that blue bar is where we have decided is the bladder neck. That's where you form a little bit of a triangle where the bladder comes up and then makes a slope down. We want to make sure the bladder neck is preserved because the bladder neck needs to be able to close for the semen to be able to shoot forward. So we tell the robot, do not resect the tissue over the bladder neck. Then we have number three, which is the lateral lobes. Those are the tissue that makes up the bulk of the prostate, and we want all of that to be removed. And then as we get to the far end of the prostate, where you have the yellow area, those are what we call the Viru protection zone. That's where the ejaculatory ducts enter into the prostate, and those need to be maintained for you to maintain ejaculation. And the most important one, which we stay far away from, is your sphincter, which allows you to maintain your continence. So I will show you a video about how this is done. And I'll try to, I know we're cutting a little bit close on time, so I'll try to. So this is a setup. The patient is prepped and draped under general anesthesia. We have all of our monitors all set up under sterile condition. That is the ultrasound probe that was going to be first placed in the rectum to see the entire prostate. Next, a camera will be put in through the penis, which is the cystoscope. And again, I know it seems a little barbaric. This is all while you're completely asleep, so you're not going to feel anything. Under vision, we can see the scope going inside the prostate into the bladder. We lock everything in place. Once we lock everything in place, we do all of the mapping that we spoke about, where we decide which parts of the prostate we want to cut out, which parts we want to preserve. And you tell us beforehand, like, hey, I really want to maintain that ejaculation. We'll be very conservative around those zones that we like, the bladder neck and the virum montanum. You tell me, I really don't care about ejaculation. It's not important to me. I want you to maximize the opening, and we can be a little bit more aggressive in those areas. So this is us just doing all of those mappings, and I'll kind of speed ahead of this a little bit. And this is really, I would say, the most important part of the procedure, because where we map it determines where the tissue will be resected. And once we've finished all of the mapping, this you can see is like a strong water jet, like you would use on a power wash on a deck, that goes back and forth, very precise, very specific. I have my foot on the pedal that is watching it all the time to make sure it is not going beyond our area of resection. I can increase or decrease the power as it's going on, and it goes back and forth, and gets rid of the tissue. You'll see next, as we get near that viromontanum, near the area where the ejaculatory ducts enter, it slows up the power, and it makes 2 passes back and forth on one side and then the other. And you can see in the video kind of what it would look like visually as that water jet goes through. And there it made 1 pass. Now it's going to go back and it's going to make the 2nd pass to do the 2nd part of the prostate. So the really great thing about this procedure is those really large glands, like 100 grams, 150 grams, you can treat them with the aquablation and not have to go through the open or robotic surgery that where you have to keep a catheter in for 14 days and go through the risk of a big surgery. Once all of that part is done, the cameras come out. We put another camera in, just like the system we would use for a TURP procedure to help decrease any bleeding. And in the original trials that they didn't actually have the doctors go back in. Well, we found that there was some bleeding coming from the bladder neck that would lead to a higher risk of needing a transfusion. So by us going in there and cauterizing those couple bleeders, it has decreased the risk of any need for transfusion to the same rates as a TURP, which is about 1 to 2%. So these are the studies that are done, and they looked at various size prostates. Initially, their first study was for smaller glands between 30 to 80 ml, and they increased the size of the glands up to 150. And they found that regardless of the size, you got a very good symptomatic relief. And even the bigger glands did just as well as the smaller glands, which is not the case with the TURP typically. And so when they compared a TURP to aquablation, they found that 5 years out, the patients with aquablation had a better relief of their symptom scores. That was that IPSS score sheet we spoke about earlier. And they had a lower chance of needing a retreatment and additional procedures. So if you find that these are symptoms that are affecting you, if you like to have a workup done, if you're interested in learning more which procedure may be the best for you, if you obviously need a procedure, you can give us a call at this phone number. I'm currently a part of Summit Health in New Jersey Urology, and we have office locations in both Edison and Old Bridge. And now I will go ahead and open it up for the questions and answers section.
All right. Our first question is, as PSA test does not tell you if the symptoms you have are due to BPH or prostate cancer, what is the value of this test in the first place?
That's a good question. So basically what I'll tell you is if you have a low PSA, the value is that it rules out cancer. It is in extremely rare cases you have a low PSA and you still have cancer. So if your PSA is typically, if you're in your 50s, under 2, and for older patients under 4, the chance of you having prostate cancer is very, very low. So if your number is low, that's where it's useful. If the number is a little bit elevated or a little bit higher, that's where it becomes a little bit more tricky. And that's where we don't know whether the elevation is coming from cancer or not. So when the number is elevated, it triggers us to either do a biopsy of the prostate to take some samples of prostate tissue to see if they find any cancer. Or what we're doing a lot more recently in the last couple of years is getting an MRI of the prostate, which often tells us is there any areas of the prostate that are suspicious for cancer, and do a more targeted biopsy of those spots. Unfortunately, the MRI is also not a perfect test because it can miss up to 20% of cancers, but it gives us a little bit more information and allows our biopsies to be a little bit more higher success rates in finding the cancer compared to just doing a random one.
Our next question is there anything to the saying, use it or lose it when it comes to BPH?
So I guess the question is, I'm not sure exactly what the question is, but I think part of it is BPH is there. you're using it every day because your bladder is urinating to the prostate. But in terms of sexual function, in whether ejaculating daily to help the semen to go through, really does not matter. So let's say you were abstinent and had no ejaculation for 1 year, or you do it every single day. Neither of them is going to make a big difference. Now, there are some studies that have shown that more frequent ejaculation may potentially risk your chance of prostate cancer, but I'm not sure if any of that is anything that is really that significant. By not ejaculating, your prostate doesn't get smaller, it doesn't change in size. A lot of that is unfortunately related to a hormonal level. But in terms of bladder health, decreasing how hard the bladder has to work, whether it's through medications or through a procedure, can help with preserving that bladder function in the long run. I'm not sure if that answered the question or not, but.
Our next question is, can taking finasteride reduce the prostate size and also reduce any existing tumor which shows prostate cancer?
So yes, finasteride absolutely can reduce the prostate size. It does take anywhere between 6 months to 12 months to decrease the size of the prostate. In terms of prostate cancer, some people get scared because they read a warning that taking finasteride increases your risk of prostate cancer. And if you ask most urologists and most of the guidelines, they find that that warning is based off of data that was not interpreted properly, and that there's really no significant increase or decrease in risk of prostate cancer by taking finasteride. So unfortunately, it does not, in my opinion, taking finasteride does not increase your chance of prostate cancer. It doesn't decrease your chance of prostate cancer, but yes, it does make it smaller, but often at the expense of some sexual dysfunction in many men. The one thing finasteride will do is that after 6 to 12 months, your prostate will get smaller and your PSA number will also get cut by 1/2. So it is important when we're talking about prostate cancer screening, and let's say we're using the PSA of 4 as our normal cutoff. If you've been on finasteride for, let's say, 1.5 years, a normal PSA needs to be really under 2, because you have to always double the number that you have to get to your true PSA.
Our next question is, all of these procedures are only done once BPH is confirmed. For example, once no other sinister causes are identified. I ask because I'm curious if invasive procedures involving needles can cause other prostate-related problems. For PCA, my understanding is that there is some controversy around if needle biopsies can inadvertently lead to spread.
So that's a very good question. There are certain cancers that we used to think, especially like kidney cancers, we would often never do a biopsy because we worried that if you put a needle in the kidney mass, that you might theoretically see the cancer outside the kidney and in the tract where the needle goes in. For prostate cancer, that is, we do not believe that it causes any chance of you spreading cancer, because the only way that you can diagnose prostate cancer really is by doing a prostate biopsy. Now, we will never ever do a prostate biopsy if you have a normal PSA or we think that your chance of prostate cancer is low. We will only do a biopsy if we think that there's a high risk of it. Every patient who has a prostate cancer diagnosis essentially has had a biopsy done at some point to diagnose that condition. And we found that doing a prostate biopsy does not risk spreading the cancer anywhere else. The other good thing about prostate cancer is that for the most part, most prostate cancers are very slow growing cancers that take several years to progress. But there are more aggressive varieties that can go much more rapidly. And once they spread outside the cancer, are unfortunately no longer curable. So our goal really with all of the prostate cancer screening is to try to diagnose the more aggressive ones and not try to overdiagnose or overtreat the slow growing ones that you may die with instead of from. So to summarize, no, I do not think that doing a biopsy increases the spread of cancer risk. Doing multiple biopsies, there are some reports of causing some other issues such as erectile dysfunction. But again, this is really after many, many multiple biopsies, typically not from one or two.
Our next question is, my doctor requested a urodynamic test. What is this?
So your urodynamic test is a test that I will often do for patients where I'm not sure if your symptoms are coming from your prostate enlargement and obstruction or other bladder-related issues. So in order for you to urinate, you have to be able to, one, have a strong bladder that can push the urine out. And number two, have a nice wide opening for the urine to go through. So let's say we do a workup and you're having a lot of symptoms. You're having a weak flow, you have to push or strain, you're getting up multiples of times a night. Well, we look inside with the camera and there's no scar tissue. The prostate itself doesn't look that big. The bladder shows some changes where the bladder may be a little bit weaker. And we don't know whether the prostate is really the main problem and whether surgery is beneficial or not. So we'll do a urodynamic test where you will come to the office, we'll put a small wire into your bladder, one into your rectum, and they have little pressure sensors that measure the pressures in your bladder and in your abdomen. And we slowly fill your bladder up with water. While the bladder is filling up, we're looking to see if there's any evidence of bladder overactivity, where the bladder is squeezing when it's not supposed to. And then we're going to ask you to urinate into a urinal. While you're urinating, it's going to measure what is the pressure in the bladder as you go to pee. If you're urinating at very high pressures and the flow is weak, that means the bladder is working really well, it's squeezing really hard, but it's really, really slow coming out because of a blockage. In which case, doing a procedure in the prostate is probably going to be helpful in treating your symptoms. If you find that when you go to urinate, you're having very low pressures along with the low flow, the issue may be that the bladder is just weak. It's not able to squeeze as well as it used to be. At that point, doing a surgery may or may not be helpful. And that's where you make a decision whether it's worth taking on that risk of doing a procedure or not.
Our next question is, what about desmopressin? I took it for many years for my diabetes insipidus.
Sure. So desmopressin and one of the newer medications that's similar called Nocturna is one that's often used by urologists to treat patients who have nocturia, where you're getting up multiple times per night. And the reason for that is increased urine production at nighttime. So if you're getting up multiple times a night because you're having small amounts of urine due to irritation of the bladder from the prostate, those are not going to be that effective. And we normally help to distinguish that by having you do a diary. We're going to write down for 24 to 48 hours every time that you pee during the day and at nighttime and what volumes you have. And we compare how much urine production do you make at night versus the daytime. In many men, especially as you get older, when the urine production shifts to a much higher volume at nighttime, and that is what's driving the getting up at nighttime, those medications can be effective in decreasing the nighttime urine production to help you sleep better.
Our second to last question is, please give us a range of years of efficacy comparing TURP, TURP, with UroLift and Aquablation.
Sure. So there's a lot of data out there. And I would say from my personal experience and from review of all the data, I find that UroLift typically is good for about 5 years. In some patients, maybe good up to 10 years out. So less durable than some of the other ones. The TURP I find to be typically good for about 10 years, maybe more. The Aquablation is obviously a much newer procedure. And based on the 5-year data, it appears to be maybe a little bit more efficacious than a TURP. And I would say, if I were to guess, realistically speaking, when you're looking at prostate volumes that are less than 50 grams, 50, I think a TURP is probably going to be very efficacious for a long time going because you can remove a large part of that prostate tissue. And even if more grows back, unlikely will need additional treatment. Once you get above the 50 gram, and especially above the 100 gram, think the aquablation is going to be a much better and long-lasting opening, because you're going to be essentially removing much more tissue in that procedure in one setting than you typically would from a TURP. So I would say you'll live about 5 to 10 years, a TURP and aquablation between 10 to 20 years, where the aquablation maybe will have a better long-term durability for the larger glands.
Our final question is, can male pelvic floor dysfunction be a cause of urinary problems which are normally attributed to BPH?
That's a good question. I think pelvic floor dysfunction is definitely something that we work up. And that is often where we will focus our efforts if we find that we are having, when we do the workup where we don't see any evidence of significant prostate enlargement or obstruction, either through volume and ultrasounds or cystoscopic guidance. And we find that the urodynamic evaluation often can be helpful in that part, where we can determine whether the issue is a bladder issue or prostate issue. And typically, I think of pelvic floor dysfunction as kind of the last resort option when you have sort of worked up the more common causes. So I don't think it is the main source of men's BPH symptoms, but it definitely is a possible, and they can mimic them very similarly. And one option that we didn't really discuss too much is something called pelvic floor physical therapy. And while we typically often use it for women for their overactive bladders or stress incontinence from coughing and sneezing, it definitely plays a role, I think, in many men as well. And I found that it can be efficacious and equally as useful compared to some behavioral changes or some medications. But it unfortunately will never replace surgery if the underlying issue really is the prostate obstruction. And it's really a kind of a mechanical obstruction. It's kind of like having a bathroom sink that is clogged. And the only way you're going to make it better is to go in there and remove the clogged hairball. And so I think pelvic floor dysfunction is one of the options that we work up during this process. And if you find that you're not responding to BPH medications or procedures, then the pelvic floor is definitely some area that is going to be used during that treatment algorithm.
All right, that's the conclusion of our Q&A portion. Thank you so much again, everyone, for joining us virtually here at Hackensack Meridian JFK University Medical Center for our webinar, Navigating Prostate Health, Understanding BPH. And thank you again to Dr. Nakota for presenting today's webinar. I hope you all have a wonderful rest of your day.